Hi, I'm Christine Fisher, a professor at University of Colorado. So today I spoke about gynecologic cancer updates at the 2022 ASCO meeting. I started with an introduction to molecular testing in endometrial cancer and talked about an oral first-in-class agent, selinexor, that accumulates p53 within the nucleus and was tested within an unselected endometrial population, but then as an exploratory analysis presented at ASCO was looked at within the molecular subtypes as broken out by the Cancer Genome Atlas. So this includes POL-E or ultra-mutated with a very favorable prognosis, MSI high or MMR deficient, which have the next most mutations, no specific molecular profile or endometrioid adenocarcinoma, which are p53 wild type, and then p53 aberrant tumors or serous-like carcinomas. These four subtypes have markedly different outcomes and markedly different opportunities, both in terms of systemic therapy as well as radiation in terms of ongoing clinical trials. The exploratory analysis for selinexor found that, as hypothesized, those with a p53 wild type or not the serous-like tumor showed a benefit in terms of progression-free survival. This is not yet practice-changing, but is very interesting data in terms of molecularly selected uterine cancer patients who might benefit from this therapy. I then turned to cervical cancer and touched on two abstracts that were presented in the oral gynecologic cancer session. The first was a subgroup of KEYNOTE-A26, which demonstrated benefit of the addition of pembrolizumab to first-line GOG 240 regimen, paclitaxel, platinum, plus minus bevacizumab, and found that regardless of the PD-L1 expression or CPS score, that a benefit was seen across that population. This is now practice-changing and is incorporated within national guidelines, as well as approved by the FDA based on the KEYNOTE-A26 study. The next abstract within cervical cancer I covered looked at tisotumab, which is an antibody-drug conjugate to tissue factor. It is approved in second and later line treatment of metastatic and recurrent cervical cancer, and this study looked at various combinations, so tisotumab, pembrolizumab in the upfront setting, tisotumab, carboplatin in the upfront setting, and then tisotumab combined with pembrolizumab in the second and third line setting. This combination showed promise throughout these cohorts, with ORRs ranging from about 40% to about 55% within the carboplatin tisotumab arm. So again, really interesting combinations. We currently have approval for this drug within the metastatic population and may see an expansion in the future based on long-term data. Finally, I touched upon ovarian cancer, and in this case, it was the Athena Mono trial, which looked at rucaparib after carbotaxol and surgery in patients who had at least a partial response. And this, again, is a promising study. We do not yet have survival data, so not currently changing standard of care, but a suggestion that these patients, particularly the homologous recombination deficient patients, show a substantial benefit in progression-free survival. So this will be one to keep your eye on. Again, not yet changing standard of care, but very interesting data within this population. Thank you.